little loud while you speak. Your voice is a little less audible. So I welcome you. I mean, your voice is, you know, it's a little less audible. You need to speak up while you're present, right? Maybe use a headphone if you can.
How is it now, sir?
It's better. It's better.
Okay.
Maybe get close to the laptop or whatever you're using. So I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. Today we are not doing a topic, but we are doing a series of topics. And basically, this session was idea of the residents, and the idea behind was to prepare yourself for the anatomy that that shows in the exam. And for that particular reasons that we're not presenting one topic but multiple small topics, we do not have an expert panelist today. So Dr. Yassar is our outgoing chief resident. He is finished his residency and is due for his exam, and he will be taking us to the general anatomy review, which will be based on the exam. You should all take part in this session, even if you don't have an exam. So Dr. Yassar, can you please start?
Sure, sir. I am starting. So today we are discussing regarding the general overview of anatomy. We have all been through various detailed sessions regarding the anatomy. We have covered the supratentorial anatomy, followed by most of the portion of infratentorial anatomy, as well as ventricular anatomy. So today I will be presenting a brief overview of all these portions, and with a slight orientation towards what's more relevant with the examination. So the contents of my presentation today are going to start with the basic anatomy, bony anatomy of the skull and the various foramina and the contents of these foramina, followed by a supratentorial anatomy, which will deal with the hemispheric anatomy as well as the ventricular anatomy, comprising of all the four ventricles, both the lateral, third, and fourth ventricles. This will be followed by a brief infratentorial anatomy, in which we will also be discussing about the cerebellopontine area. So all of you can see this picture in front of you. This is the picture depicting the internal portion of the skull, or as we call it, the cranial base. This is the cranial base. Once the calvaria has been removed, this is what you will observe within the cranial base. The cranial base is actually divided into three fossa. We have got an anterior cranial fossa, middle cranial fossa, and then we have this posterior cranial fossa. These fossa are actually divided into three fossa by various
Dr. Yassar, we lost you in between. We lost your voice in between.
Okay, sir. Can you hear me now?
Yes. Dr. Pravat, is Dr. Yassar audible now? You can use the chat box and answer.
Okay. So the lesser wing of sphenoid divides the anterior cranial fossa from the middle cranial fossa. In the center, in the body of sphenoid, we have got various portions. This central depression is the sella turcica, which houses the pituitary gland. Anterior to it, this depression is the limbus sphenoidale, and anterior to it is the plenum sphenoidale. This elevation is the tuberculum sella, and this posterior elevation is the dorsum sella. Also to note here that this medial most projection of the lesser wing of sphenoid is known as the anterior clinoid process, whereas the lateral projection of the dorsum sella is known as the posterior clinoid process. Now, these processes are important, especially when we are dealing with the internal cerebral artery and optic nerve. These relations are of quite significant. Also, then if we talk about the boundary between the middle cranial fossa and the posterior cranial fossa, we've got this bone. This bone is known as the petrous part of the temporal bone. This superior ridge of the petrous part of temporal bone is what divides the middle cranial fossa from the posterior cranial fossa. In life, this area is actually covered or roofed by another dural fold that is known as the tentorium cerebelli. So you see that posterior cranial fossa comprises of the infratentorial compartment. This infratentorial means it's lying beneath the tentorium cerebelli. And over the tentorium cerebelli sits the occipital lobe of the brain and a part of the temporal lobe of the brain. And anterior cranial fossa houses the frontal lobe of the brain. The middle cranial fossa houses the temporal lobe of the brain. Over the tentorium cerebelli sits the occipital lobe and a part of temporal lobe, whereas beneath the tentorium cerebelli, on this bony cavity resides the cerebellum or cerebellar hemispheres posteriorly. You can see a depression over here where the cerebellar hemispheres are going to be accommodated. In the center, you've got a big opening. This is the opening which will let the way for the medulla oblongata to be connected to the spinal cord. This is known as the foramen magnum, the largest opening. Now, as we are talking about the foramina of this still base, let me just revise a few foramina. This is the anterior cranial fossa. In this one, in the middle, we have got this separate bone. This is known as the ethmoid. Within this ethmoid, we have got various small bony openings. These are actually this is the cribriform plate. Cribriform means that something with various perforations. So these perforations are for various fibers of the olfactory nerve. In the center, we have got this bony prominence, which is known as the crista galli. The crista galli is the region where the falx cerebri is going to be attached. So both the cerebral hemispheres are divided by the dural fold known as the falx cerebri, and it gets a part of its attachment into the region of the crista galli. Also, anterior ethmoidal foramen and posterior ethmoidal foramen give way to the anterior and posterior ethmoidal nerve over here. We already discussed regarding the sella turcica, which houses the pituitary. It's also roofed by another dural structure that is known as the diaphragma sella. Within the diaphragma sella, there is a central opening which gives way to the pituitary stalk. This bony landmark or bony foramina is the optic canal, and in this region there will be superior orbital fissure. You can see a part of superior orbital fissure on this side. You can see this opening. These orbital fissure connect the skull cavity, the superior orbital where
Dr. Yassar, there's some connectivity issue. There's some connectivity issue on your side, Dr. Yassar. Your voice is breaking.
V1 and V2 portion. Hello?
Yeah, Dr. Yassar, there's some connectivity issue on your side. I guess the voice is breaking in between. Your video is not. It's kind of stopping in between. Can you hear me? No, it's still breaking. Your voice is breaking. You can. Dr. Yassar will just take a couple of minutes to sort this issue out. It's kind of raining in Karachi. Connectivity issues are, possible. So the idea behind this session was so that, we all have boards. We have exams in Pakistan. We have internationally, we have boards. And, moreover, the exam, the anatomy that's basically asked in the exam is the same. So, the idea was that, we can orient you with just small topics which are important. I was just waiting for Dr. Yassar to return and, restart his presentation.
Excellent.
Please mute yourself, Dr. Yassar. I think you've returned.
Hello?
Yes, Yassar, we can hear
Hello?
you. Yassar, we can hear you.
Hear me now, sir?
Yes, we can hear you.
Sorry, sir, for the interruption. I have some connectivity issues over here.
So you can start whenever you're ready.
Yes, sir. I'm just starting. Can you see the screen now, sir?
Yes, we can see the screen and the.
Okay, sir. I was talking regarding the anatomy of the superior orbital fissure. So this opening is the superior orbital fissure, which is in between this lesser wing of sphenoid and the greater wing of the sphenoid. This opening is actually a pathway for the third, fourth, sixth, and the V1 portion of the trigeminal nerve to enter the orbit. The V2 portion goes via the foramen rotundum, which cannot be seen in this image, but we can see this oval-shaped foramina, which is the foramen ovale. This gives pathway for the mandibular division of the trigeminal nerve to exit, and we can see a small foramina over here. This is the foramen spinosum, and the significance of foramen spinosum that it gives way for the middle meningeal artery to enter the skull cavity, and we can see this serration over here. It is for the anterior and posterior division of the middle meningeal artery. Also, we can appreciate this lacerated or jagged margined foramina. Its margins are lacerated, so it's known as the foramen lacerum. Foramen lacerum in life is actually closed by fibrofatty tissue, and it does not give an entrance to anything, but in its side, like a door is opening into its lateral wall over here, from where the internal carotid artery enters. So this is the opening of the carotid canal. The carotid canal from the skull base opens into the lateral wall of the foramen lacerum, and the internal carotid artery, once it enters, it actually traverses the foramen lacerum to come into lie into this portion. So this would be the region of the cavernous sinus. Then a few other foramina are within the posterior fossa. We have got the jugular foramen. We have got the jugular foramen into the petrous part of the temporal bone, and we have got the internal acoustic meatus over here. But I will show them into a separate picture. Also, just at the level of the foramen magnum, we have got the condylar canal and the hypoglossal foramen. Okay, now this is another enlarged image of this same structures we just discussed. Just the thing is that the plenum sphenoidal can be seen more clearly. Also, the foramen rotundum can now be seen. So this is the round-shaped foramen rotundum, which gives way for the maxillary division of trigeminal nerve. So it's an entrance into the infratemporal fossa. So you see that this cavity, actually the internal brain skull, is connected to the infratemporal fossa, also to the orbit as well, and via here to the base, skull base, via the jugular foramen. This portion of the bone is the clivus, against which the pons and medulla oblongata usually rest. So this is another picture of the sphenoid bone. You can see that it's an bed-shaped bone which has got two lesser wings and the greater wing of the sphenoid. These are the same foramina we discussed. We have a foramen ovale, rotundum, and spinosum within it. Foramen spinosum is known because it is located on the skull base side at the base of an spine. So in this picture, various bones have been given a separate color so that we can understand how the skull base, how the skull cavity or the cranial fossa is actually formed by various bones. This blue-shaped bone is the frontal bone. This gray shape is the ethmoid bone. We already discussed about it. The yellow one is the sphenoid bone, the body, the lesser wing, and the greater wing. This pink-shaped bone is actually the temporal bone, which has got two parts: the squamosal or the smooth part of the temporal bone, and then the petrous part of the temporal bone. The other significance of petrous part of temporal bone is that it houses the middle and inner ears within its cavity. Also, we have got this green parietal bone over here, and posteriorly we have got the occipital bone. We can see that a part of clivus is made by the occipital bone and remainder by the sphenoid bone. Also, jugular foramen can be more clearly appreciated over here. It lies in between the petrous part of temporal bone and the occipital bone. So this is an enlarged view
of the same figure, which shows the posterior fossa per se. So this is the petrous part of the temporal bone we just described, and this is an enlarged view of the jugular foramen that can be appreciated over here. This is the internal acoustic meatus. We will be dealing with its anatomy in detail later on. You see that in life, beneath the tentorium cerebelli, there is the cerebellum, and then we have got the midbrain, pons, and medulla oblongata. And various cranial nerves arise from these structures as well. Now, these are the cranial nerves, third, fourth, all the way to the 12th cranial nerve. So these cranial nerves also need to exit. The cranial nerve third and fourth actually pass in the region of the clavus and the region of the petrous apex, along with the cranial nerve 6 into the middle cranial fossa, along with the cranial nerve 5. But the cranial nerve 7 and 8 exit via the internal auditory meatus. The 9th, 10th, and 11th exit via the jugular foramen. Whereas within the foramen magnum, we have got a hypoglossal canal on the side, via which the 12th cranial nerve exists. Another interesting thing is that the 11th cranial nerve has got two portions. It has got a spinal portion. It has got a cranial portion. The cranial fibers are actually the fibers of the vagus from the nuclei of the vagus that it has lent for a period of time, while the spinal fibers are the actual fibers of the accessory nerve. So they travel along with medulla oblongata via the foramen magnum, and then they join the cranial fibers within the skull cavity, and then both the cranial and spinal fibers exit via the jugular foramen. So this is another lateral view of the petrous part of the temporal bone. We can see the internal auditory meatus more clearly in this picture. Also, you can see that the jugular foramen is divided by this bony landmark, and this separation is completed by a fibrous band in life. So jugular foramen is tested within the examinations, and the jugular foramen is in life divided into two portions. We have got a pars vasculosa and pars nervosa. We will be discussing about these two portions as well. So you can see that here I have placed a picture of the Greenberg, in which you can see that there are two portions, pars vasculosa and the pars nervosa. The pars vasculosa is named so because of the larger component of the sigmoid sinus that exists via the jugular foramen, while the pars nervosa comprises of the superior petrosal sinus along with two cranial nerves. The cranial nerve 9 and 10th cranial nerve actually exit via the pars nervosa, whereas the cranial nerve, cranial nerve 9, that is the glossopharyngeal nerve, exists via the pars vascularis, whereas the other two cranial nerves exit via the pars nervosa. So various syndromes are associated with the jugular foramen syndrome. These are known as the jugular foramen syndromes that occur due to the various lesions that are encroaching upon the contents of the jugular foramen. And depending on the cranial nerves involved, they are classified into 6 types. We have Wernicke, call it Sicard, Villaret, Tapia, Jackson, and Schmidt syndrome. And there will be different clinical presentation depending on the cranial nerves or the sympathetics involved. So this is a view of the sutures that are actually present within our cranium on the external cranial wall. We have got the central coronal suture, we have got the sagittal suture in the midline. The point where the coronal and the sagittal suture intersect is known as the bregma. We have got the nasion just at the base of the nose. We have the most prominent portion over the forehead that is known as the glabella. We have got this famous region that is known as the pterion, where the greater wing of sphenoid, temporal, parietal, and frontal bone are actually anastomotic. This is the site of the middle meningeal artery being traveling over here associated with the extradural hematoma. Also, this region just behind the frontozygomatic arch is the region of the key burr-hole, which we use to get access within the anterior and middle cranial base at the same time. So it's a key to the skull cavity. That's why it's known as the key burr-hole. Another important landmark is the asterion, where the lambdoidal suture, the parieto-mastoid and occipito-mastoid sutures fuse. And this is the site of the burr-hole when we are doing a retrosigmoid craniotomy. Intraoperatively, we have got an emissary vein that is lying at this region. So this marks the junction of the transverse and sigmoid sinus. So once you make a burr hole over here, you identify the transverse sinus in a superior aspect and the sigmoid sinus in the lateral aspect. So again, this picture is taken from Greenberg, which deals with the various areas within the lateral hemispheric surface. These areas are the Brodmann areas. Each area is assigned a specific function. We can see the Brodmann area 44 over here highlighted, which is formed by a part of the pars triangularis and pars apicularis. This portion deals with the motor phase of the speech. Brodmann area 8, that is the supplementary, Brodmann area 8, that is the area of the frontal eye field. Brodmann area 6, that is the supplementary motor area. We have got Brodmann area 4, that is the motor cortex. We have got the Brodmann area 312, that is the somatosensory cortex. And also we have got the famous supramarginal gyrus and the angular gyrus. And these are the area 40 and 39. And we have got the visual cortex in the superior and inferior lip of calcarine sulcus, that is Brodmann area 17. We have got the transverse temporal gyrus of the Herschel, that is located in the superior temporal lobe, that is Brodmann area 41 and 42. I will be dealing with the anatomy of all these areas of the brain later on, but the purpose of this picture is to give you an orientation regarding the various Brodmann areas. Okay, so now coming back to the Roton, the anatomy as per Roton, you can see this picture, you can see the air over here, you can see the orbit over here, and you can see the brain, the lateral cerebral surface lying over these regions. We can appreciate that even behind the ear, there is a slight continuation of the temporal lobe. So this entire portion is the lateral surface of the temporal lobe, and you can see that it extends to the posterior margin of the pinna as well. You can see the Sylvian fissure over here on the lateral hemispheric surface that is dividing the temporal lobe below from the frontal lobe above. We can also appreciate the central sulcus over here. The key to identify central sulcus is that it is the largest sulcus that comes down but does not open into the Sylvian fissure directly. So you can see that this fissure is not opening into the Sylvian fissure directly, this sulcus, and this is the central sulcus. And the area or the gyrus which separates it from the Sylvian fissure is the subcentral gyrus. This one is present in almost 90% of the specimens. Anterior to the central sulcus, we have got the precentral gyrus, we have got the postcentral gyrus, and anterior to the precentral sulcus, we have got the superior, middle, and inferior frontal gyrus. Also, with regards to the Sylvian fissure is a large sulcus. Actually, it extends down deep into the brain cavity, extending to the opticocarotid. This is not just a superficial landmark, but if we talk about its superficial parts, we have got a posterior ramus, we have got an anterior horizontal and an anterior ascending ramus. The anterior horizontal and anterior ascending ramus enclose a triangular area that is the pars triangularis. And this posterior portion is the pars opercularis, called opercularis because it forms a lid, an opercula, a covering of the Sylvian fissure. And it's actually forming a covering for a lobe that resides deep within the Sylvian fissure, that is the insula. And anteriorly, just lying over the orbit, we have got the pars orbitalis. The operculus and triangulus we already discussed are part of the Brodmann area 44, which is the motor speech area. A deficit in this area would lead for the patient to have motor part of the aphasia, in which he won't be able to express himself, but would be able to understand. If we trace the Sylvian fissure posteriorly, it turns upward into the parietal lobe, and a part of the parietal lobe is actually around the Sylvian fissure, and this is known as the supramarginal gyrus. And within the temporal lobe, we have got this superior temporal sulcus, and the part of the parietal lobe that is around the superior temporal sulcus is the angular gyrus, the area 40. Both of these together make up the Wernicke's area, along with the part of the posterior lip of the superior temporal gyrus, and this one, if damaged, will lead to the sensory aphasia. Mind it that this occurs only on the dominant cerebral hemisphere. In 90% of the people who are right-handed, the left hemisphere is dominant. Even in people who are left-handed, again, in more than 50%, the left is dominant. So in this picture, I have highlighted the Sylvian fissure, the superior extent of the Sylvian fissure. This is the temporal, this is the frontal lobe, and this one is the parietal. This is the central sulcus being highlighted. This is the precentral sulcus. In between both is the precentral gyrus. This is the postcentral sulcus. These both are opening within the Sylvian fissure. The central is not. This is the part of the frontal lobe. The precentral gyrus has not been highlighted. It's also a part of the frontal lobe. This is the parietal lobe. The occipital lobe is divided not by an actual sulcus, but on the lateral surface, we have got an indentation of the parieto-occipital sulcus. The parieto-occipital sulcus is more prominent on the medial surface, but there's an indentation present over here. And if we connect this indentation on the lateral surface to an occipital notch inferiorly, it's the boundary between the occipital lobe and the parietal lobe. So this is the superior frontal gyrus, the middle frontal, and the inferior frontal gyrus. This is the precentral, postcentral gyrus, the subcentral gyrus. Again, within the skull, we have got concept of various craniometric lines. These are known as the Taylor-Houghton lines. We draw a line from the nasion back to the inion, known as the nasoinian line. We mark the midpoint of the nasoinian line. If we go just 2 centimeters behind the nasoinian line, this is the site where the motor area can be localized. So if we mark this point 2 centimeters behind the one half of the nasoinian line, or we go just above the external auditory meatus, or another method is that you can go 3 to 4 centimeters behind the coronal suture, you can easily mark the motor cortex. So these are the methods, Taylor-Houghton lines, via which we can do craniometric markings prior to doing our craniotomies. Also, Sylvian fissure can be marked. We take a line from the lateral angle of the lateral canthus of the eye, lateral orbital wall, and we join it posteriorly to the 3/4 point of the nasoinian line. We will get the Sylvian fissure. So the concept of the central lobe of brain is that it is composed of the precentral and postcentral gyrus. It also extends on the medial surface as the paracentral lobule. This is the concept of the homunculus. We know that there is representation of entire human body. It is an Italian word which means a little man. So you can see on the medial hemispheric surface, we have got representation of toes, ankles, and knees, whereas on the lateral surface, we have got representation of trunk, arms, going all the way down to the tongue, jaw, and lips. These are the regions from where the motor fibers actually arise. So it's known as the motor homunculus. These are the famous corticospinal and corticobulbar fibers that arise from the pyramidal cells of the brains within the layers of the cerebral cortex. On the sensory side, we know that the thalamocortical fiber, the spinothalamic fibers carry sensation from entire body. They synapse within the thalamus, and the thalamocortical fibers are going to stimulate these areas of the brain. Hence the representation. This is the supplementary motor area or premotor area, which deals with the planning of various motor activities. The supramarginal, you can see that it's around the Sylvian fissure, and the angular gyrus, I have not shown, it's over here. Okay. Now, in this picture, the author has actually opened up this opercula. I previously mentioned that these are the opercula or lids covering a structure that is residing deep within the lateral surface of the brain. So the Sylvian fissure has actually been opened in this picture. You can see the frontal lobe is being retracted upwards. This is the anterior portion. This is the temporal pole. This is the frontal pole. And once we open up the Sylvian fissure, you can see a lobe that is residing deep within the Sylvian fissure that is known as the insular lobe. Again, insula is surrounded by a limiting sulcus that is known as the circular sulcus. It's actually triangular shaped. This is the region of the apex. This is the region of the base. Anteriorly, we have got 3 to 5 short gyri. Posteriorly, we have got 1 to 2 long gyri, and they are separated by this sulcus that runs in the center of the insula. This corresponds with the central sulcus on the cerebral hemisphere and is known as the central sulcus of the insula. The circular sulcus is the limiting sulcus. We can see that this portion of the superior temporal gyrus that is retracted away is the temporal opercula. This one is the frontal opercula. and posteriorly we've got the parietal opercula behind the central sulcus. So opercula means lid. It's a lid covering the insula. This is another view in which we can see the relationship of how deep does the Sylvian fissure actually extend. So this is view from an anterior aspect. You are looking from the front backward. So this is the frontal lobe that will reside obviously over the orbital part of the anterior cranial fossa. And this is the lateral portion. You can see this is the temporal pole, the temporal tip. This is the frontal opercula when you are seeing from the front. This is the temporal opercula. This is the Sylvian fissure on the surface, but you can see it extends deeper. So this is just the superficial component, and it has got a deep component as well. The component of the Sylvian fissure that lies between the frontal and temporal opercula is the opercular part. While once these opercula are lying over the insula, this portion of the Sylvian fissure is known as the insular part of the Sylvian fissure. But it does not end over here. It has got a further component that is known as the sphenoidal portion, because it extends the medially till the anterior clinoid process in the region of opticocarotid recess as well. So this region is the sphenoidal component of the Sylvian fissure. So you've got an sphenoidal component, insular component, opercular component, and a superficial component of the Sylvian fissure. So it's actually a Sylvian cistern, to be more correct. And within this region is where the middle cerebral artery and its branches actually travel, and they arise over here from the internal cerebral artery, and they come out over here from the surface. Also in this picture, you can have the concept of the anterior perforated substance. These are the olfactory stria. This is the olfactory bundle in the center. This is the gyrus rectus of the frontal lobe. These are the orbital gyri, and you can have concept of this portion as well. This has been labeled anterior segment. It's actually the anterior segment of the medial most projection of the temporal lobe. So medially in the temporal lobe, we have got hippocampus. Anterior to it, we have got the uncus. So this is the anterior segment of the uncus that has been shown over here. Again, in this picture, we are actually looking from downward at the base of the brain. You can appreciate the olfactory tract over here. You can appreciate the optic nerves coming together as the optic chiasm, and then dividing into the optic tracts going on both sides. We can see the pituitary stalk in the center. Anterior perforated substance lies lateral to this region. Also, here is the Sylvian fissure in the insular region, and you can see this thing, lamin insulae. Lamin insulae is actually a projection that is created on the surface of brain by an underlying white matter tract that is known as the uncinate fasciculus. The uncinate fasciculus connects the orbital part of the frontal lobe, or the olfactory part of the frontal lobe, with the temporal lobe, and its projection on the surface is known as the lamin insulae. It's a gateway to the sphenoidal portion of the Sylvian fissure. Also, you can see amygdala. Amygdala lies in the medial portion of the temporal lobe. I told you already, it's nothing but it's a structure that lies deep to the uncus. So on the surface, the cortical area is known as the uncus, but if you scrape it downward, you've got the area of gray matter known as amygdala. Also, you can appreciate the midbrain over here. You can see that just anterior to the region of the midbrain, we have got the cranial nerve 3 arising. So, and we have got the both crus cerebri over here. So this will be the region of the interpeduncular fossa. This is an important concept from examination point of view, because cranial nerve 3 here are medially are laterally related to the uncus, and any compression or mass effect on one side can lead to the compression over the oculomotor nerve over here, and lead to the ptosis and paralysis of the oculomotor nerve. Along with it are the fibers. The parasympathetic fibers would lead to the ipsilateral dilatation of the pupil as well. Also, posterior cerebral artery lies in this region, and severe herniation in this region, the transitor herniation, can lead to the PCA compression, and infarcts can occur. So in this picture, we have further dissected the temporal lobe. So this is the temporal lobe. This picture, we are looking from the downward, but we are looking downward from the above, but we have dissected out the surface of the temporal lobe. So to give you an understanding how this is taken, this is the midbrain. Laterally, we have got the various cisterns over here. Obviously, here we have interpeduncular cistern. Here we have got the ambient cistern, crural cistern and the ambient cistern. You can see that this is the tip of the temporal lobe and the medial post part of the temporal lobe. This region is known as the uncus. Uncus has got two segments, the anterior segment, the posterior segment, and the anterior segment houses the amygdala, whereas the posterior segment houses the hippocampus. Within the hippocampal anatomy, you can see that there are various structures that are arising from the hippocampus. We have got choroidal, we have got the fimbria of the hippocampus, we have got the dentate gyrus of the hippocampus, and they will travel backward, and the fimbria will lead to the formation of the fornix. Also, if we consider the temporal lobe of the brain houses the temporal horn of the lateral ventricle. So this is the medial surface of the temporal, the superior and the medial surface of the temporal lobe. Anteriorly, we have got a smooth portion that is known as the plenum polare. Posteriorly, we have got a rough portion with the various gyri. The most anterior transverse temporal gyri is known as the Heschel's gyrus, which is the primary auditory area. I already described this region. While posteriorly, we have got the other transverse temporal gyri. This anterior smooth portion houses the turn of the middle cerebral artery. The most posterior middle cerebral artery arises and then takes a lateral bend at this level. So this point is also known as the Sylvian point, where the posterior most branch of the lateral middle cerebral artery takes a lateral course. We can appreciate the temporal horn part of the lateral ventricle that resides within the temporal lobe. So again, a surface of the medial temporal lobe, you can see the uncus. You have got an anterior segment of the uncus, the posterior segment. We have got the parahippocampal gyrus and collateral gyrus. These gyri are actually present on the basal surface of the temporal lobe that I will be describing. Also, you can see this vallicula. It's an opening within the Sylvian fissure in the region of the temporal lobe. So this is the view of the temporal lobe. Once we have unroofed the temporal lobe, you can see this intraventricular view of the temporal lobe. Most medially, you have got the parahippocampal gyrus, then you have got the fimbria over here that are arising from the hippocampus. This is the hippocampus. It has got three portions, the head, the body, and the tail of the hippocampus. The head has got multiple serrations anteriorly, which resemble the paw of an animal or a feline paw. So it's known as the Parse hippocampus, followed by the head, body, and the tail. The tail of the hippocampus actually continues as an indusium griseum white matter fiber on the surface of the corpus callosum. The uncal recess is a indentation in between the amygdala and hippocampal portion of the head. Also within this picture, you can see various structures within the lateral ventricle. Collateral eminence is an eminence created in the floor of the temporal horn of the lateral ventricle by the collateral sulcus. The calcar avis is an indentation created within the region of the atrium of the lateral ventricle by the calcarine sulcus. So, coming back to the surface, we have already discussed these regions, so I'm going to skip it. If we go further from the surface, we dissect deep down, we have got the medial part of the frontal lobe that we are going to discuss now. We have already discussed the superior temporal gyrus. Then we have got three temporal gyrus, superior, middle, inferior, divided by superior and inferior temporal sulci. We have discussed regarding the central sulcus as well. In this picture, you can see that if you dissect out the supramarginal gyrus on the surface, deep down, you have got the atrium portion of the lateral ventricle. So this picture is showing the relationship of atrium to the supramarginal gyrus. Now the medial hemispheric surface. We are done with the medial hemispheric surface of the temporal lobe, but also the frontal and parietal lobe have got a medial hemispheric surface. Then example of medial hemispheric surface is like a roll. There are three sheets of structures that are stacked one upon another. In the innermost structure, we have got the corpus callosum, which is the white matter connection in between the two cerebral hemispheres. This is the first layer. The second layer is the layer of the cingulate gyrus that wraps around the corpus callosum. And the third layer is the layer of the cerebral cortex, that is the superior frontal gyrus. Anteriorly, behind we have got the central lobule that is known as the paracentral lobule. And posterior to that, we have got the precuneus and then the cuneus portion. You can see that in this medial portion of the occipital lobe, you have got a sulcus that is running deep. This sulcus is known as the calcarine sulcus. This calcarine sulcus divides the medial occipital lobe into a small portion above that is known as the cuneus, and a long tongue-shaped portion below, which is known as the lingula. Because of an anterior tongue-shaped projection of this portion into the temporal lobe, this is known as the lingula. Within the superior and inferior banks of the calcarine sulcus, we have got the primary visual area that we already discussed, the Brodmann area 17. Also, you can appreciate the parietal lobe over here. This is a further zoomed in picture of the same medial surface of the cerebral hemisphere. You can appreciate the corpus callosum, the cingulate gyrus lying just above the corpus callosum. The corpus callosum and cingulate gyrus are separated by a callosal sulcus, whereas the cingulate gyrus and superior frontal gyrus are separated by a cingulate sulcus. If we trace this cingulate sulcus posteriorly, it actually has a superior ascending ramus that is known as the ascending ramus of the cingulate sulcus. The ascending ramus of cingulate sulcus has got another name. This is known as the Parse Marginalis. This is another thing which is tested on examinations, because on MRI, you have got a bracket-shaped appearance of this Parse Marginalis of the anterior of the ascending ramus of the cingulate sulcus. Anterior to the Parse Marginalis, you can see we have got the paracentral lobule. So anterior to the Parse bracket on an MRI, we have got the central sulcus and the motor area. So this is the central sulcus. The central sulcus does not come entirely on the medial surface, but just ends over here. We have got the somatosensory in the posterior portion and the motor area in the anterior portion. So you can see that anterior to the ascending ramus of the cingulate sulcus, you have got the central sulcus. So this is the concept of the Parse bracket on an axial cut of MRI. Posterior to the ascending ramus, we obviously have got this triangular quadrangular shaped area that is known as the precuneus. The precuneus forms part of the parietal lobe, and behind the precuneus region, we have got the cuneus, part of the occipital lobe. The occipital lobe and the parietal lobe are divided by this parieto-occipital sulcus. This is more prominent on the medial surface. On the lateral surface, just an indentation. So on the lateral surface, we divide it by an imaginary line. Also, you can appreciate the base of the temporal lobe on this picture as well. You can appreciate that we have got in the temporal lobe base, we have got the parahippocampal gyrus lying on the inferior surface most medially. Then we have got this gyrus that is known as the occipitotemporal gyrus. The parahippocampal and occipitotemporal gyrus are separated by the collateral sulcus. This collateral sulcus in the floor of the temporal horn will form the collateral eminence, whereas laterally we have got the inferior temporal gyrus, which I will be showing you in the next picture. So this is a further view of the medial surface. Once a dissection has been done, you can appreciate the lateral ventricle. It is roofed by the corpus callosum. Just over the corpus callosum and beneath the cingulate sulcus, there's a white matter tract running known as the cingulum. We have got various portions of the corpus callosum being described. We have got the genu, the rostrum of corpus callosum, the body, and the splenium portion. This is the region of the thalamus. We have got the posterior portion of thalamus known as the pulvinar. So again, we have got in the cerebral cortex, the arrangement is such that we've got a superficial layer of the cerebral cortex, which is actually made up of the gray matter. And then we have got deep down various basal ganglia, which are also made up of the gray matter. So it's an example of a cake which has got an icing of the gray matter on the surface. And then within it are embedded various fruits. These are the masses of the gray matter that are known as the basal ganglia. In between, we have got the actual material of the cake that are the white matter fibers. So the white matter fibers connect these interlying deep areas within of the gray matter. Those are the basal ganglia in this region with the overlying cerebral cortex. That is also the gray matter. So these are the various white matter projections you can see. So one white matter projection that goes all the way, radiates all the way to the cerebral surface is known as the corona radiata. It comes over here and forms a compact bundle at this level, which is known as the internal capsule. So these white matter and gray matter are interspersed together. Also, you can appreciate the caudate nucleus over here. You can, in this picture, it has been shown more clearly. The caudate is a part of the basal ganglia. We've got the head of the caudate, the body and the tail of the caudate. The tail goes on to end within the anterior segment of the temporal lobe. Mind it, I told you within the anterior segment we have got the amygdala. So this is the caudate nucleus. It lies laterally, so forms the lateral wall of the lateral ventricle. So this is the concept I was talking about previously. This is the ascending ramus of the cingulate sulcus that is known as the pars marginalis. On an axial cut of MRI, this is the pars marginalis. This is a commonly tested examination question in which they ask you to localize the central sulcus on the basis of an axial cut of MRI. So this is the pars marginalis, just anterior to this sulcus that does not go all the way to the midline. It is deficient on the medial surface. It is known as the central sulcus. So anterior to pars marginalis, this forms the pars bracket sign. You can see on both ends there are brackets being formed, is the central sulcus, and anterior to it is the motor cortex, that is the precentral gyrus, and this one is the postcentral gyrus. Other differences are this one is more thicker, this one is thinner. Also, there is a hand knob formation or omega sign formation over here. This area represents the motor neurons of the hand area on the homunculus of the motor area. So anterior to it, we have got the frontal lobe, we have got the superior frontal, middle frontal gyri. There's a T-shaped sign formed over here in which the superior frontal sulcus that divides the superior frontal and middle frontal gyri comes to unite with the precentral sulcus. Also, posterior postcentral sulcus can be visualized in this image as well. This is the postcentral sulcus, which forms a Y-shaped parenthesis. These are the cups of the Y, this is the limb of the Y, and they form a Y-shaped parenthesis around the pars marginalis. So again, I already described this structure. This is the innermost layer, that is the corpus callosum. The cingulate gyrus, both are separated by the callosal sulcus, and this one is the cingulate sulcus. That is separates the uppermost layer. This is the parieto-occipital sulcus. This is the posterior aspect in which you can visualize the lingula, the calcarine, the cuneus, and separated by the calcarine sulcus. That runs deep downward, and it runs so deep on the medial surface that it comes to indent the medial wall of the lateral ventricle portion of the atrium. So this medial indentation of the calcarine sulcus into the medial wall of the atrium is actually known as the calcar avis, which is a projection you can see in intraventricular landmark. This is the paracentral lobule. This is the precuneus. It's a part of the parietal lobe. Behind the ascending marginal ramus, posteriorly bounded by the parieto-occipital, inferiorly by the cingulate. This is the basal hemispheric surface of the frontal lobe. This is the gyrus rectus, separated via the olfactory sulcus from the orbital gyri. There's an H-shaped sulcus over here. Anteriorly, we got anterior orbital, lateral orbital, posterior and medial orbital gyri. This is another dissection which gives you a concept how the surface is related to the deep structures. If you remove away this portion of the frontal lobe, you can see that just above this region lies the genu of the corpus callosum and rostrum of the corpus callosum, and above the rostrum of the corpus callosum lies the lateral ventricle. Also, this is the view of the basal part of the temporal lobe. You can see that most medially on the basal surface we have got this structure that is known as the parahippocampal gyrus. Here we have got the occipitotemporal gyrus, and laterally we have a continuation of the inferior temporal gyrus. The inferior temporal gyrus is separated from the occipitotemporal gyrus via the occipitotemporal sulcus, and the occipitotemporal gyrus is separated from the parahippocampal gyrus via the collateral sulcus. If we go anteriorly, this is the region of the uncus. You can see the apex of the uncus, the anterior segment, the posterior segment of the uncus. This uncus is separated from the parahippocampal gyrus via another sulcus that is known as the rhinal sulcus. So this is a view which shows how the ventricles are actually arranged. We saw the surface anatomy. We can appreciate that the lateral ventricle is housed by the lateral cerebral hemispheres. Then we have got foramen of Monro, which provide a pathway to the third ventricle. This is housed by the diencephalon portion. It is the thalamus and the hypothalamus. And from this arises this cerebral aqueduct of Sylvius that lies behind the midbrain, going on to the region of the pons and medulla oblongata, where lie the fourth ventricle. And finally, the fourth ventricle has got three openings: a posterior midline opening known as the foramen of Morganti, and two lateral openings known as the foramen of Leschka. So this is the picture which shows the both lateral ventricle opening into the third ventricle, which is a singular structure in the midline, and finally giving way to the lateral walls of the third ventricle are formed superiorly by the thalamus, inferiorly by the hypothalamus. We can also appreciate the arrangement of those deep masses of the gray matter over here. You can see that the various gray matter are arranged such that the basal ganglia, this portion is known as the lentiform nucleus. The medial portion is the globus pallidus internus. This is the globus pallidus externus, and this portion is known as the putamen. These three together are known as the lentiform nucleus. Over here, we have got the head of caudate in a cut section, and this one is the thalamus. So thalamus forms the floor of the lateral ventricle and the medial wall, lateral wall of the third ventricle, whereas the head of the caudate forms the lateral wall of the lateral ventricle. Also, the temporal lobe has been shown in a cut section over here. You can appreciate how the hippocampus is arranged. The hippocampus word comes from the example of a sea buffalo. So it's a S-shaped structure. You can see that hippocampus floors the temporal horn. So the temporal horn of the lateral ventricle has got hippocampus in its floor. So within the lateral ventricle, we have got various structures. In this picture, this is an schematic diagram. You can appreciate the central division of the lateral ventricle. You've got a central septum that separates the lateral ventricle. In the midline, you have got the thalamus, and thalamus is surrounded by two C-shaped structures. One of these structures is the fornix, which is also known as the hippocampo-mammillary tract. This originates from this mammillary body as the column of the fornix, goes behind, forms the body of the fornix, and then at the posterior aspect of the thalamus is continues as the crus of the fornix, and then continues as the fimbria of the fornix. As we already discussed, the fimbria were within the medial portion of the temporal lobe to terminate within the region of the hippocampus. So they actually arise from the hippocampus. So the origin is from the fimbria and comes anterior to terminate in the mammillary body. Also, you can see that this is the hippocampus that lies in the floor of the temporal horn of the lateral ventricle. So this transparent area gives you a concept regarding the lateral ventricle. This is the frontal horn. This is the body of the lateral ventricle. This region is the atrium, where various structures are actually opening. We have got the body is opening, occipital horn is opening, and the temporal horn is opening into this. So it's a concept of a room in which various structures, various rooms are opening combinedly, a corridor. And anterior laterally, you have got the temporal horn of the lateral ventricle. So this is a superior view in which we are looking from above downward. You can have an orientation regarding the mediolateral arrangement of these structures. Within the midline, you have got the septum pellucidum. You can see that the frontal horn anterior to the foramen of Monro is not separated by the septum pellucidum, but are separated by the cerebral cortex actually. In the midline, you have got the septum pellucidum dividing the body of the lateral ventricle. In the floor, you have got this fornix running. You have got the mammillary body, you have got the columns of the fornix, and you've got this body of the fornix. Posteriorly, you've got the crus of the fornix. Both crus of the fornix are joined together in the center by a commissure that is known as the hippocampal commissure, and then they go infero-laterally to end in the temporal horn. You can see in this picture that the temporal horn is located in a lateral relationship with respect to the body. So this is the fornix going within the temporal horn. This is the fimbria of the fornix, crus of the fornix, body of the fornix, column of the fornix. The column take an antero-inferior sharp turn around the region of the foramen of Monro that we'll be seeing in the next picture. So this is in view when you look from the anterior aspect. This is what you get. This is an anterior view of the lateral ventricle. Again, you've got the same septum pellucidum in the midline. You have got the inferior arrangement of the hippocampus. You have got the column of the fornix in the center. This picture has two added structures in comparison to the previous picture. We have added a green shaped structure. This green shaped structure is known as the caudate, and we have added this red colored structure. This is actually the corpus callosum that we have added in this picture. The caudate is also C-shaped structure around the thalamus. Previously, we saw how the fornix surrounds the thalamus. Here we can see how the caudate surrounds the thalamus, and the caudate has got a head, body, tail, and ending into the amygdala. And we've got the corpus callosum over here as well. You can see that anteriorly, there are these fibers that are projecting outward from the corpus callosum. They actually cross in the region of the genu and the rostrum of corpus callosum, and they connect various parts of the frontal lobe with each other. So this is known as the minor crossover, that is known as the forceps minor. Posteriorly, in the region of the splenium of the corpus callosum, we have got a larger bundle which interconnects the two occipital parts of the cerebral hemisphere. This one is known as the forceps major. So this is the region of the forceps major. And also there's another sheet that arises from the splenium and body of corpus callosum. This white matter sheet is known as the tepitum. So tepitum is like a large, you can say, covering that goes on to cover the atrium of the lateral ventricle on a lateral aspect and goes downward and sweeps over the temporal horn of the lateral ventricle. So tepitum forms the roof and the lateral wall of the temporal horn. Also, it forms the lateral wall of the occipital horn of the lateral ventricle and of the atrium as well. So this is the same picture. When we are looking from downward above, you can see the forceps minor part of the corpus callosum. This is the lateral ventricle. Now, the important thing is you can see how the lateral ventricle is arranged. It lies above the rostrum portion. So rostrum is within the floor of the lateral ventricle, more specifically the floor of the frontal horn. And the fornix is running in the midline. So medial part of the floor of the lateral ventricle will be formed by the body. Then we have got this crux that lies posteriorly. So posteriorly, so the anterior portion of the atrium will actually be formed by this crus fornix. You can see this is the atrium of the lateral ventricle. Anterior to it we have crus fornix. How is caudate related? You can see this is the lateral ventricle. So caudate lies, the head of the caudate lies just lateral to the frontal horn and body of the lateral ventricle. Then the body of the caudate is separated from the lateral ventricle because of thalamus lying over here. So a similar picture, not going into detail, just the tepitum can be seen over here. Tepitum is a large sheet-like covering that covers the lateral aspect of the temporal horn and the roof of the temporal horn and the lateral aspect of the atrium. So this is a picture from the rotund now. This is a picture of an interhemispheric approach. You can see the falls in the midline. You can see the retraction of the temporal lobe being done. Various
Dr. Yassar, your voice is not audible. We lost you there. Dr. Yassar, can you hear me?
Sir, can you hear me now?
Yes, Dr. Yassar, just one point. How much of your presentation is left? Because we're nearly at the end of the time. And
so I have got a large portion remaining.
so can we continue this next week as well? Because we won't be able to finish this. And I think we are very near the time where we start our clinical activities. So
Sure.
I think we can continue this next week, and you can start with the ventricles, and so we'll take it up from there.
Okay, we can do that.
Thank you, Dr. Yassar, for such a excellent presentation. Shows your grasp on the anatomy, and obviously you've done the hard work and creating making this presentation. So since we do not have an expert panelist, we will not be doing any discussion for it. We'll all see you all next week, and we'll be continuing our presentation where Dr. Yassar will be orienting us with the exam-related anatomy. Even Dr. Pravat is appreciating your effort, and he's saying it's a very nice presentation. Thank you, Dr. Yassar. We'll continue this week. Thank you, everyone. See you all next week.
Okay, sir. Okay. Thank you, sir.